so in the next 40 minutes, I'll do my best to give you an overview of interstitial nephritis. I'm going to show you lots of photos. So sit back, relax, and enjoy it, okay? The key is you don't need to memorize it. Okay, so I have nothing to disclose. And among the intrarenal causes for acute kidney injury, 5% is due to interstitial nephritis, while the most common cause is ATN, is about 80%. So together, tubular interstitial injury is the most common cause for intrarenal related AKI. Let's talk about acute interstitial nephritis, AIN, a common cause of AKI. It is the second leading cause of acute intrinsic kidney disease. As a matter of fact, AIN may be even more common since we don't commonly do the kidney biopsy. Okay, I'm not going to go over the detail. You can read it. Those are detailed statistics. Okay, renal biopsy still remains the definitive diagnostic modality. Know that the fibrotic changes may be seen in AIN, and the AIN with the fibrotic changes can be seen as early as 7 to 10 days. Okay. The granuloma patterns can also occur in AIN, and usually they are drug related. Remember this, interstitium of kidney is normally not visible. If it's seen, it indicates disease process. Okay. The pathological interstitial changes are either focal or diffuse. Mainly are three things: inflammation, edema, and fibrosis. Okay. This is a pattern of interstitial inflammation. Know that tubules are relatively preserved, while there's many inflammatory infiltrate cells. In this case, many is lymphocytes, indicated by yellow arrow, with some eosinophil by blue arrow, okay, in the interstitial space. Okay. This figure shows there's an empty space in the interstitium, and this is indicating interstitial edema. This is a phenomenon called thyroidization, meaning there's a 10 host 4 protein fill in the tubules, while epithelium is flat, indicating tubular atrophy. And the interstitial space has a collagen protein deposit, while there's not too many inflammatory infiltrate cells. So this is a chronic interstitial nephritis pattern. Okay. So the clinical presentation of AIN has become heterogeneous. This table summarized here for you, and it's by Praga and Gonzalez. Okay, acute renal failure, hematuria, leukocyturia, and non-nephrotic range proteinuria are quite common. Know that the so-called triad, fever, rash, and eosinophilia, only seen in about 10% of AIN patients. So when there's negative triad, remember, that's not necessarily rule out AIN. So drugs-induced AIN accounts for about 70% of all cases. Okay. The mean delay between drugs and study day and AKI is about 10 days. However, though, the latent period can be as short as 1 day, seen in some antibiotics. Okay. In addition to drugs, infections or certain systemic diseases such as autoimmune disease, cancers such as leukemia, lymphoma, or acute allograft rejection can also associate with AIN. Know that 5 to 10% of AIN is idiopathic. Okay. Again, you remember this slide, right? Tubule is preserved, many inflammatory infiltrate cells with lymphocytes and some eosinophils. So this pattern, as you know now, is interstitial inflammation and is indicating AIN, and most common seen in drugs-induced. Okay, so this is seen in medulla area with a neutrophilic infiltrate in the peritubular capillary. So this condition is called medullary necrotizing peritubular capillaritis, which is caused by ANCA-induced AIN. Again, tubule is relatively preserved. There's a loss of inflammatory infiltrate cells in the interstitial space. There's also have an interstitial edema, correct? So that's an AIN pattern again. And this pattern sometimes can be seen in transplant rejection patient. Okay. So as I mentioned earlier, 70% of all AIN is caused by drugs. And in under such circumstances, it's often also called allergic interstitial nephritis. Okay. Among the beta-lactam, such as penicillin or cephalosporin, currently still remain a frequently reported cause of AIN. Now, of the quinolone, AIN has been commonly linked with ciprofloxacin. All right. Now, in terms of sulfonamide-containing antibiotics such as Bactrim or diuretic, thiazide, furosemide, as you know, they can also cause AIN. Okay. In terms of the NSAID, we know can either cause AIN or nephrotic syndrome or both. Okay. Now, in terms of H2 blockers, the AIN has been reported with cimetidine. However, AIN is extremely rare, seen in other H2 blockers such as ranitidine. Okay. Recently, we all know many data has been surfacing that PPI it's been known to cause acute kidney injury, especially AIN. Okay. Now, the one point I want to point out here is drug-induced AIN is not dose-dependent, and AIN can recur with repetitive exposure. Okay, remember that. So this is a case one. 42-year-old patient was referred by her PCP with a new onset azotemia. She was otherwise asymptomatic. Her creatinine was increased from baseline 0.9 to 1.96 in 2 weeks of period. Okay, the significant history include 1 week prior to the presentation. She went to see her PCP, presented with a cough with yellowish sputum, and she was prescribed with antibiotics and levofloxacin. Okay. Laboratory shows proteinuria, leukocyturia, and hematuria. Okay, with questionable some WBC test. Okay, also renal failure or insufficiency, should I say, with a serum creatinine 2.2. Ultrasound shows echogenic kidney. And so this patient quickly, empirically diagnosed with levofloxacin-induced acute interstitial nephritis, and antibiotics was quickly stopped, and her creatinine returned to her baseline 0.9 in 1 week. So this is a typical case of drug-induced AIN. When identified early, stop the offending drugs, renal function recover fully. Okay, case 2. 24-year-old male with a history of aplastic anemia, status post stem cell transplant, complicated by CMV, EBV, PTLD, and he was treated with rituximab and triviral cells. This patient also have ESRD due to TTP-HUS associated TMA and was on hemodialysis, and he is now post-op day 4 with a living unrelated kidney transplant. His urine output decreased from initial 750 cc per hour post-op to 20 cc per hour. Creatinine increased to 5.5 after initially going down from 6.6 to 3.7. Medication include Valside, tacrolimus, MMF, prednisone, 3 antihypertensive medication, and Bactrim. Physical exam shows a low-grade temperature, tachycardia, Not so great urine output, 480 cc in 24 hours. Some sign of a volume overloaded with a JVP of 12 centimeter and low extremity edema. The laboratory significant for proteinuria, again, hematuria, leukocyturia, and acute renal failure with a creatinine of 5.5. So this patient underwent renal kidney biopsy, and the result shows AIN, however, cannot completely rule out acute rejection. So this is a case potentially related to Bactrim-induced AIN. Now, Bactrim has been well documented to cause AKI due to AIN in native kidney. Bactrim is also known routinely used to treat PCP prophylaxis in transplant patients, and many case studies have been shown Bactrim has been associated with either delayed graft function or early graft dysfunction. Okay, so what are the mechanisms for drug to cause AIN? There's proposed, I showed here 4 potential possibilities. A, drugs may act as a heptin, which is bind to tubular basement membrane. Okay. B, the drugs may mimic certain antigen, which inducing immune response against this specific antigen. C is drugs may bind to tubular basement membrane or drop in the interstitium space and become either planted or trapped antigen in the interstitial space. And number 4 mechanism is drug itself can form an immune complex in the circulation and deposit in the interstitial space. Okay, in terms of infection-induced AIN, acute pyelonephritis known to cause AIN. Okay, other systemic infection caused by bacteria, virus, or parasite also can be responsible for AIN. Okay, this is a slide shows bacterial infection with a neutrophil infiltrate in the kidney. So this is a pathognomonic for acute pyelonephritis. Okay, now this is a case of 3. 60-year-old lady was seen for evaluation for creatinine 1.91, and this was found in a routine testing. Other lab shows a hemoglobin 11.4 with a low T-cell. The significant history include she presented with a red eye and was seen by ophthalmologist, and she was diagnosed with anterior uveitis and received steroid eye drops. Otherwise, she does not explain other urological symptoms. All right. Past medical history only significant for treated breast cancer. She's an ex-smoker and still drinking alcohol. Medication quite simple: iron, steroid eye drop, and ACE inhibitor. Okay. Physical exam shows a hypertension and red eye. The laboratory again shows a proteinuria, hematuria, myeloleucocyturia. Okay. Other serological exam are negative. So this patient again underwent renal biopsy, and it shows moderate to severe activated AIN. Together with her diagnosis of anterior uveitis, this patient have a condition called Tenniel syndrome. Okay, so Tenniel syndrome is an idiopathic and was thought a possible autoimmune condition related, and commonly seen in adolescent girls. The presentation usually is uveitis with some constitutional symptom and, of course, renal insufficiency. All right. It's been thought associated with a chlamydia infection. Good news is children with this condition usually with very good prognosis. However, some adults may require systemic steroid treatment. Okay. A few words on idiopathic AIN. Idiopathic AIN is uncommon, only 5 to 10% of the case. Common presentations of fever, but infrequent with eosinophilia or rash. Okay, the infiltrate usually is mononuclear in nature. All right, I'm going to just a few words on granulomatous interstitial nephritis, called GIN. This is a courtesy from Dr. Bijou from Brigham Renal Hospital Pathology Department, who kindly provided me this slide. So drug is still the most common cause for GIN, okay, followed by sarcoidosis and idiopathic. Another few words on IgG4-related disease is one of the rare causes of AIN. Okay. IgG4 disease is a systemic disease involving multiple systems. Okay. For kidney, in the kidney is involvement usually as tubulointerstitial nephritis or membranous glomerulonephritis. Now, the characteristic of this disease is the infiltration of lymphoplasmacytic infiltrates with rich in IgG4 plasma cells. As I mentioned before, IgG4-related interstitial disease, the characterized feature is increase in IgG4-rich plasma cells in the interstitium. Okay. Another feature is glomeruli is relatively intact. Histologically, IgG4 interstitial nephritis presented with variable degrees of fibrosis or inflammation, which divided the disease into three patterns. Pattern A is AIN with minimal fibrosis. B is AIN with some fibrosis, but more prominent of inflammation. C has a very dense fibrosis and with a palsy cellularity. So this is an example of a pattern A IgG4. As you see here, there's an increase of IgG4 plasma cells, while in the interstitial, there's minimal fibrosis. Versus pattern C, you can see there's a dense fibrosis in the interstitial space and also have a hypocellularity, shown in this slide. Okay. Laboratory-wise, IgG4 interstitial nephritis can be detected with increased serum IgG, IgG4, or hypergammaglobulinemia. Some percentage of patients can also have a hypocomplementemia or eosinophilia or very weak positive ANA. Another feature is patient with IgG4, sometimes you can see a bilateral, markedly enlarged kidneys. In fact, there's a series of which I didn't put the slides in from MGH. It shows a patient, you from the renal ultrasound may see quote unquote renal mass. And in fact, a lot of patients get biopsy because the renal mass. And as a turnout result was IgG4 disease. Okay. All right. Another rare cause of AIN is a condition called hypocomplementemic interstitial nephritis. Okay. Similar to IgG4, is also have a protein deposit to the tubular basement membrane. That's why it's potentially suggesting an autoimmune-related condition. However, unlike IgG4, which, as we mentioned, has a rich IgG4 positive plasma cells, in this condition, usually the deposit to tubular basement membrane is IgG and C3. Okay. Similarly to IgG4, this condition, the glomerular condition, is equally intact. Okay. The cause of AIN usually resolved with the removal of offending drugs or treating the underlying infection. However, take note that likelihood of recovering is inversely proportional to the degree of renal failure. In fact, about 30% of the individual who has AIN may end up require dialysis. Okay. Individual, though, when they have pattern shows as scattered infiltrates, usually associates a better prognosis. Okay. And 50% of patients who has an idiopathic AIN usually left with some form of renal dysfunction. Okay, how do you treat AIN? If it's a drugs induced, of course, we halted the offending drugs and run its own course. Okay. If the infection, you treated the underlying disease. Another point I want to mention here is that steroid currently still remain the mainstay of treatment. I listed here what kind of condition they use for steroid, okay? Cyclophosphamide and cyclosporine has been using it for AIN, usually is under the condition of steroid-resistant idiopathic AIN. MMF also been used, usually used for steroid-dependent or steroid resistance, okay? Or someone absolutely cannot tolerate steroid, then we may use the MMF, which is, I have done that before, and I see equally effective result, okay? In terms of plasmapheresis, the role of such, unclear. Okay, what is our take about corticosteroid? I listed lots of information here for you to read, okay, when you go home or when you have the free time. But very briefly, in terms of prospective study, simple. Right now, there's no prospective randomized control trials, okay, to assess the effect of steroid in treating AIN. Although, though, it does have some data suggest that early initiation of steroid may potentially improve the prognosis, or when kidney recover, tend to have a superior renal function. Okay, but if you look at up to date also suggests if you plan to use a steroid under that circumstances, we recommend it do renal biopsy first, which is I'm going to mention later. Okay, now how about retrospective study? One word, no conclusion. As simple as that. Okay, all right. So what is the current recommendation for using steroid? Steroid has been recommended to treat patients who do not improve with the serum creatinine after 3 or 7 days after remove the offending agents or treat it with underlying disease. Like I mentioned earlier, when you want to use a steroid, renal biopsy is recommended before you start it. For that, for 3 reasons. 1, you want to confirm indeed this patient have AIN. 2, you want to rule out there's other etiology causing this patient's renal insufficiency. 3rd, if it's indeed AIN, you wanted to see the degree of chronicity. If there's too much chronicity involved, may not be so effective. Okay. Now, steroid also recommended to use as an empiric treatment for patient who you may have a strong suspicion of drug-induced AIN. However, you are not able to biopsy this patient, and you may try empiric treatment. Okay. Again, I listed a recommended doses or regimen that you can use it. Okay. So the take-home message: the trial of AIN, fever, rash, and eosinophilia, is only seen in 10% of AIN. So negative trial does not rule out AIN. Drugs are a common cause of AIN, so one practice in your clinic should have a very high suspicion for drug-induced AIN. Why? Because it's a delayed intervention may result in a poor renal function. Okay. And steroids still remain as a mainstay treatment option for AIN. However, though, clinically, the optimal doses and the duration, how long should you treat AIN, still not very clear. Okay, now let's move on to chronic interstitial nephritis, CIN. It has a diverse spectrum of etiology. However, its pathological pattern has been remained fairly homogeneous, meaning interstitial fibrosis, less pronounced infiltration, and in this case, usually it's a mononuclear cell in nature, okay, and tubular cell atrophy. I'm sure you by now, you remember this slide now. The phenomenon called thyroidization, right? Tubular field of 10 host 4 protein. Epithelial is a flat, indicating tubular atrophy. The interstitial field was a collagen protein with a scarce cellularity. So again, this is a CIN pattern. Okay. Now, the clinical presentation of CIN usually is asymptomatic, or simply just patient have a chronic renal insufficiency and presented as such. Okay. The important point I want to point out here is patients with the CIN tend to develop anemia earlier. And about 50% of patients by the time with the CIN, they usually also present with hypertension. Okay. The causes of CIN are many. Hereditary diseases such as ADPKD, medullary cystic disease have been associated with CIN. Metabolic issues such as hypercalcemia, hypokalemia, hyperoxaluria, cystinosis, they are also reported to cause AIN. Okay. Drugs and toxins equally can cause CIN, such as analgesics, lithium, cyclosporine, cisplatin, or some Chinese herbal medicines such as Aristolochic acid. Immune-mediated diseases such as lupus, vasculitis, Sjögren's, sarcoidosis, hematological condition, lymphoma, leukemia, those are or multiple myeloma. They can all associate with CIN. Okay, all right. So this is a granuloma pattern with multinuclear giant cells with many inflammatory infiltrate cells. In this case is eosinophil. So in addition to that, you see now there's also a fibrosis in the interstitial space. So this is most likely is a drug-induced GIN. As you recall earlier, I mentioned granuloma pattern can also associate with AIN, correct? And most likely is associated with the drugs. So this slide, this pattern can be still drug-induced AIN. Okay, all right, case 4. 49 years old female presented with a 4-month history of nausea, fatigue, nocturia, and weight loss. The past medical history is only significant for herpes for about 2 years ago, and she self-treated herself with a Chinese herbal medicine for 3 months, and in fact, she has been taking this Chinese herbal medicine for on and off about 18 months, and last use was 5 months ago. She denies using NSAID, and physical exam, other than hypertension, was unremarkable. Laboratory shows low potassium, low bicarb, renal insufficiency, anemia, proteinuria again, and glucoseuria, sort of Fanconi-like pattern. Okay, ultrasound shows a normal kidney, and the Chinese herbal medicine analysis confirm this medication contain Aristolochic acid. Okay, so this is a renal biopsy slide. However, this is from different patient. I couldn't find the slide from this particular case. Okay, because the case actually provided by my friend from China, Beijing, University of Beijing, and here you see there's a marked or dense, should I say, impressive interstitial fibrosis and impressive tubular atrophy, right? And there's almost acellularity, all right? And however, the pattern is glomeruli is relatively intact. So again, this is a CIN. By now, you should recognize the pattern now. This is a CIN, and in this particular case, it happened to be caused by Aristolochic acid. So the Aristolochic acid, or AAN, is a rapid progressive interstitial nephritis leading to ESRD. The very first case actually reported from Belgium after an outbreak from a 100 young woman who attended a weight loss center. Okay, Brigham nephropathy is also a entity of AAN, so that you should know that. Okay, now patient with AAN usually presented, like I say, extensive interstitial fibrosis and impressive tubular atrophy. This morphological features has another characteristics, which is there's a very unique pattern, which is a gradient of intensity ranging from most severe in the outer cortex to the less involvement in the inner cortex and medulla. I guarantee you, once you take one look, you will never forget. Very, very dramatic. Okay. In addition to that, Aristolochic acid also have a remarkable interstitial hypercellularity. In fact, some cases may be acellularity, okay? Another feature of that is glomerula also relatively intact. Okay. Patient with AAN usually is asymptomatic. And how do we make a diagnosis? Usually it's through blood drawn and find that there's an abnormality of indicating renal insufficiency. And more common seen in young women, okay? And patient usually present with mild proteinuria, which is, I'll elaborate a little bit more later. Patient also present with anemia, however, the degree of anemia is out of proportion to the degree of tubular interstitial nephritis. Okay, 80% of patients usually associate with hypertension. Like I say, there's a percentage of patients also presented with a Fanconi syndrome. Okay, so if you see a Fanconi syndrome or there's a proximal tubular injury, also think about aristolochic acid or other Chinese herbal medicine. The serum creatine downstream time is significantly shorter. Okay, the course from AIN or CIN or acute renal failure to ESRD is in this subacute fashion. However, though, in general is faster than any other type of interstitial nephritis. Okay. Now, in terms of proteinuria in AAN, they are not albuminuria. Instead, they are low molecular weight proteins such as beta microglobulin, cystatin C, clear cell protein, or retina binding protein. Okay. So when you see those low molecular weight protein in the urine, usually signify proximal tubular injury. In addition to that, this protein usually would appear in the urine before the decline of GFR. So personally, for me, it's quite excited because this protein can be potentially serve as a biomarker for the diagnosis of aristolochic acid in the future. All right, so this is another condition. As you see here now, there's a cystic dilatation in the interstitium, correct? So this is a lithium toxicity. Also a CIN, as I point, you can see here now there's a fibrosis pattern in the interstitium, right? However, though, the best diagnosis for lithium-induced toxicity, in fact, actually is a radiologic, because usually you will see a multiple microcyst. Usually they're pretty uniform, okay? Analgesic nephropathy. Analgesic can cause a CIN, can also cause a papillary necrosis or papillary calcification. More common seen in women, okay? Equally associated with hypertension, steroid pyuria, or nocturia. Okay. Again, there's a study shows analgesic has been associated with anemia or uroepithelial malignancies. Okay. All right, what do you need to know about myeloma-induced CIN? Only one thing. Cas nephropathy. Okay, so here, as you see now again, there's a tremendous interstitial fibrosis. There's also infiltrate cells in the interstitium. There's a multinuclear giant cells. Okay. However, the hallmark is this cast here. It has a pear color standing in a PAS. Okay, and so this is indicating light chain protein deposition, and this is Cas nephropathy associated with multiple myeloma. Unlike Cas nephropathy, this slide here shows there's a large cast with darker color staining in PAS. Okay. In addition to that, you see in the interstitium area, there's many space, right? So those are indicating tubular atrophy. In addition to that, there's also shows a collapsing pattern of glomeruli. And what is this? This is HIV nephropathy. Okay, case number 5. 69-year-old man with a history of diabetes, hypertension, CLL, chronic back pain, and CVA, who was admitted for evaluation of renal insufficiency. His creatinine has been worsened from 1.1 to 3.2 in 2 months. And otherwise, other than he has reported anorexia, early satiety, and weight loss, he in general feels pretty well, okay? Past medical history, as I mentioned earlier, medication, quite simple, aspirin, statin, ACE inhibitor, metformin, and he also takes NSAID daily, okay? Physical exam, no fever, again, hypertension, okay? Also indicating some volume depletion with dry mucous membrane, no elevation of JVD, and no edema. Okay, lab shows low sodium, low bicarb, low albumin, some mildly elevated potassium and renal insufficiency with a creatinine 3.4. Okay. Other serological tests in general are negative, except the UPAP and urine immunofixation ratio are positive for kappa light chain. Okay. Urine is relatively not impressive. Okay. Renal ultrasound shows normal kidney size, except it's a normal kidney size. Okay. Now, the biopsy, okay, is, I'm sure now you're expert how to read the pathology slide now. Interstitial fibrosis, okay, a loss of infiltrate cells, and again, there's a multinuclear giant cells here. So this is a granuloma pattern with a multinuclear giant cells. In addition to that, this patient's tissue also show C3 and C68 positive macrophage, and also have CD20 and CD5 P cell and T cell co-expression. So the final diagnosis for this patient is CLL-associated GIN. Okay. A few words on CLL-associated GIN. It's a rare condition. However, it's more common seen in elder patient. Okay, you need to raise your antenna when elder patient with a history of CLL who presented with worsened kidney function or identified to have interstitial disease. Also think about CLL-associated GIN. Okay, also important to know that this condition may occur early in the course of CLL. How do we treat them? One point. The crucial thing is not to overlook interstitial nephritis patient, just like what I mentioned earlier. Have your antenna up. Any CLL patient worsened kidney function, you may want to consider do a kidney biopsy. All right, this is another pattern. Again, it's a chronic pattern with interstitial fibrosis with infiltrate in the interstitium. The only thing different is that this other than, we also have a granuloma, but without multinuclear giant cells. And so what is this? This is called non-necrotizing GIN, can be due to sarcoidosis. This is another pattern. By now, you should be able to tell. This is clearly is a CIN pattern with multinuclear giant cells, diffusely or scattering everywhere, and then here is a granuloma, okay? So this is another sarcoidosis, except this is much more advanced. Okay, another case. 66-year-old woman with recently diagnosed with a hypersensitivity pneumonitis, wax and wane, dry cough, along with a fatigue and weight loss for 9 months. Creatinine initially was 0.8, progressively worsened to 1.4, then to 2.5 when she was hospitalized for community-acquired pneumonia, okay? 2 days prior to her being seen, her creatinine further worsened to 3.5 and calcium 13.3. Medication-wise, important thing is that she's not taking NSAID. Okay. Physical exam, no fever, again, hypertension, no volume overload, though there's a crackles at the lung base and there's a murmur and no edema. Okay, laboratory shows mildly low sodium, potassium is 3.9, again creatinine 3.2, okay, calcium 13.5, vitamin D 35. Urine, again, hematuria, proteinuria, glucosuria. This is the biopsy pattern. It's impressive, diffuse granuloma pattern, correct? And with multinuclear giant. So this one is a GIN again, and most likely is due to hypercalcemia in sarcoidosis. Few words on sarcoidosis. It affects kidney mainly due to hypercalcemia. It's about 10 to 15% patients with sarcoidosis have a hypercalcemia. However, patients tend to have more common to have a hypercalciuria. Okay, so also make sure to check urine. More common in men, and patients with the sarcoidosis with either usually the presentations are atypical, they can be only kidney involved without systemic involvement. And the good news is sarcoidosis usually responds pretty well with a steroid. Okay, move on to another condition. So the arrow indicated here is a nucleus inclusion body with a virus in the center. So what is this? This is a BK virus nephropathy. This is another, let me see. Okay, this is another BK virus nephropathy example. Again, CIN pattern, right? Tremendous interstitial fibrosis with a hypocellularity. This is also a nucleus inclusion body. All right. So this one here, again, CIN pattern, multinuclear giant cells. In addition to that, there's also an area with a necrotizing pattern. So what is this? This is, so this one is called necrotizing GIN, can be seen in patients with TB. Okay. Again, CIN, correct? Fibrosis, interstitial fibrosis, also impressive tubular atrophy. Okay. In addition to that, there's multiple giant lymphoid follicles and the thickened cortex. So what is this? This is a chronic pyelonephritis. Okay, so this, again, CIN, I don't think I need to repeat again, you can tell. Also a tubular atrophy. What is this? I pointed out here already, is obstructive uropathy. Okay, so remember those conditions, all right? So the cause of CIN, again, they are slowly progressive. You treat underlying disease or you treat symptoms, meaning hypertension, you treat hypertension. If there's electrolyte abnormality, you treat as such. Okay, if it's sarcoid, you treat with a steroid. Biopsy usually is not commonly done because since there's a lack of a specific treatment. Okay, so not much of take-home message. I just want to remind everybody here is herbal medicine. Always ask your patient whether they take herbal medicine because they don't volunteer to tell you. And I think this is an area require more education and research. Okay, to test, do I have time to do that? Okay, 55 years old male presented with renal insufficiency, kidney stone, hypercalcemia, hypercalciuria. Renal biopsy is shown in the pattern. And what is your diagnosis? Myeloma, TB, sarcoidosis, obstructive uropathy. Excellent, good, yes, sarcoidosis, right? We know this is a granuloma pattern associated with a hypercalcemia, hypercalciuria, correct? Yeah, the renal insufficiency mainly caused by hypercalcemia. Okay, second case, 65 years old male is a renal transplant recipient who presented with a renal insufficiency, sinusitis, hypocomplementemia. Renal ultrasound shows a renal mass. Renal biopsy shows plasma cell-rich intestinal nephritis, interstitial nephritis, with IgG C3 deposit in tubular basement membrane. What is the diagnosis? Is it B? Yes, correct. It's IgG4. So like I say, right, this can be presented with a renal mass, and usually is a plasma rich into cells deposit. Okay, all right. So I just want to acknowledge some of my colleagues who very kind, provide a lot of cases to me. Okay, I think I'm running out of time. So if anybody have a question, I'll stay behind, so come find me and we will discuss.